Dear colleagues, Kostas, thank you so much for having me here. In this case, a patient with a severe aortic stenosis and ascending aortic aneurysm. The highlights of this case is that the aneurysm is big for a short patient, a woman, 80-year-old with recent pulmonary edema. She also has, besides the severe aortic stenosis, chronic kidney disease with a last creatinine before she came at 2.3 and distal upper septum thickening. She also has coronary artery disease. She had 2 stents about 10 years ago that hold well, but she had some moderate stenosis of the circ ostium and some mild to moderate stenosis of the distal left main, non-dominant right coronary artery, and you see here also the aneurysm and the stenosis of the aneurysm of the left main, stenosis of the ostium of the left circ. So keeping that in mind, that this patient may have at some point in the future to have some coronary artery intervention, and that will make us consider which valve should place. You can see here the aneurysm of the ascending aorta, the calcification, the moderate calcification of the valve, and also you can see the calcium of the LVOT, of the aortic annulus extending to the LVOT, and the thickening of the aortic valve, the fibrosis. Also, you can see that the aorta is very tortuous, as you can see here and here. And the heart is very horizontal, so you have some difficulties here. Tortuous aorta, ascending aortic aneurysm, horizontal heart, and you have to plan this case. So you have to put a valve that in a patient with a small aortic annulus. Most likely the better valve would be a supraannular. We have low coronary ostia and the coronary artery disease, so have to put a low-profile valve to facilitate the coronary access in the future, and have very horizontal aorta and big ascending aorta that we make it difficult to advance the valve because the pushing force will maybe expand, go all to the aortic aneurysm. So, putting all this into account, then we chose the valve, the accurate neo valve, small valve. You see here the measurements. You see the big aorta. You see the calcium in the aortic annulus extending to the LVOT. The measurements are the ones that you see here. The perimeter derived area, the annulus 21, and the same for the LVOT. Not a better peripheral access, but on angiogram you see that there is no much stenosis on both sides. I chose the right side because on the left we have some difficulty pushing the wire through the bifurcation. And here you see the tortuosity of the aorta. You see the huge aneurysm for the size of this small lady. We managed to put the wire, the extra small safari wire, in a very hypertrophied ventricle, LV. You see how horizontal is the heart. And we did the pre-dilatation, very generous pre-dilatation with a 20 millimeter balloon, because the calcium was not at the, if we go back, you see the calcium is not at a critical and very dangerous point. You see, so if you see here, if the calcium is in this area, because you have some support behind it, it's not very dangerous to dilate, maybe aggressively. But if the calcium is here, then if you do an over-dilatation, you may rupture the LVOT or the annulus in an area that there was no support behind, and you have a very severe hemorrhage. So we felt pretty comfortable to do a pretty generous dilatation before we put the valve. Here's how the valve goes in. There was some difficulty pushing the valve actually in the annulus, but we managed it. Displacing the pigtail catheter, which now is in the right cusp. We couldn't manage to put in the non-coronary cusp. And see here, when in the right picture, when we open the first knob, that the valve moves in towards the LV. That's not a good sign. So here's what it should be. When we first open the first knob, so the first part opens up to hold the valve, the leaflets down. Then you open up the second one, that opens up the second part of the valve that centralizes the valve, and then you open the valve. But it's not what happened to us. You see that the first part opened. It's not maybe, I thought it moved into the LV. So I tried to pull back a little bit. By pulling back a little bit, in a case with a big aneurysm, the valve opened, the upper part of the valve opened up without opening the second knob. And actually, I was not sure where I was. So in the angiogram here, I see that most likely I'm not in the LV, and I'm in the lower part of the valve. I take another picture. I see the valve is opened above the aortic annulus at this point, this part of the valve. I confirmed here, and I open the valve. You see that it's underexpanded. I gave it a couple of minutes, and without doing anything, the valve opened up pretty well, most likely because of the good pre-dilatation. No paravalvular leak. And a good closure of the femoral artery. And the echo 2 days later showed just a Vmax of the aortic valve of 2.5. Good ejection fraction. You see the valve is well seated without any leak. And the patient 6 months after that is doing very well. Thank you very much.
Okay. Thank you. Congratulations for a slick case. Can I have a comment?
Congratulations. Excellent job. Very difficult case. With aortic aneurysm, with coronary heart disease, for difficult approach. How was the Euroscore?
The Euroscore was 6.5. 6.5.
Borderline.
Yeah. And the STS was 12.
Okay. Congrats.
So it was fine.
Short question. Did you have any doubts about the valve arches holding on to the aortic wall due to the aneurysm? Otherwise, I would consider a very good case for this type of valve.
Actually, one of the reasons we chose that valve is because of the aneurysm. We chose the valve to try to center the valve in this very, very peculiar anatomy. So, although it was not my intention to open the valve in this way, actually this backwards movement that opened up the upper part, the upper counts of the valve, help the valve to be centered and actually hold stable in this anatomy.
Okay, thank you very much.
Thank you.
And can we proceed to the next?